Good afternoon, one and all. Kindly take your seats, please. Besa. On behalf of IMA Surat, offer a not so sleepy post-lunch welcome session. Learning is always an ongoing process, and so we all should now focus on today's session.
First of all, I would like to invite Dr. Nishil Shah. Is he there? Oh. Okay. Then we forward to.
We would now call upon Dr. Yash Lapsiwala, sir. Advances are made by answering questions. Discoveries are made by questioning answers. Dr. Yash Lapsiwala, sir, will share his knowledge on selecting the right anti-diabetic medications in various clinical scenarios. He's a MD Medicine from Gitanjali University, Udaipur. He has done his post-MD fellowship program of RSSDI in diabetology from Department of Endocrinology, Lilavati Hospital, Mumbai, under guidance of internationally renowned Dr. Shashank Joshi, sir, and Dr. Vijay Panikar, sir. He has presented many papers in local as well as national conferences. Consultant diabetologist at VIP Road, Vesu, Surat.
Please, Dr. Yash Lapsiwala.
Okay, so good afternoon everyone, and thank you very much for the introduction. First of all, I'd like to thank the team IMA for this opportunity to speak in this wonderful conference. And my topic for today is selecting the right anti-diabetic medication in various clinical scenarios. So, just a minute. As you all know, diabetes is a worldwide epidemic. Worldwide, there are about 37.1 crore people having diabetes, and that number is expected to rise to about 55.1 crore by 2030. And India is said to be the diabetes capital of the world. So, in Indian scenario, it is quite necessary that we know which anti-diabetic medication can be used in which specific scenarios. And we cannot go for a one-size-fits-all approach. So this is the topic. So today we'll be covering firstly the general considerations about diabetes, treatment options, diabetes and various other comorbidities like cardiovascular disease, CKD, pregnancy and old age. So first of all, we'll cover the pathogenesis of diabetes type 2. So beta cells are necessary for the synthesis of insulin. So in the pathogenesis of diabetes, there are two main parts: beta cell dysfunction, which involves the decreased sensitivity to stimuli, as well as the beta cell depletion, and insulin resistance, which may be at the level of liver or peripheral tissues. So even before 8 to 10 years before the diagnosis of diabetes, the beta cell starts depleting. And even at the time of diagnosis, about 50% of the beta cells are already depleted. And as the diabetes progresses, most of the remaining beta cells also deplete. So early timely diagnosis and treatment of diabetes is quite necessary to prevent the complications of diabetes as well. So what are the options of therapy? Medications which improve insulin action, that is bigonides like metformin, thiazolidinediones like pioglitazone. Medicines which increase insulin secretions like sulfonylurea, which include glimepiride gliclazide, maglitinides like ripaglinide natagalinide, medications with slow glucose absorption like alpha glucosidase inhibitors including acarbose, voglibose, Medicines which increase incretin action, that is GLP-1 agonists, it includes semaglutide, liraglutide, DPP-4 inhibitors like teneligliptin, vildagliptin, sitagliptin. Medicines which increase glucose excretion, that is SGLT2 inhibitors, including dapagliflozin, empagliflozin, canagliflozin. Insulins, it may be the conventional insulin, that is the regular or the NPH insulin, or the insulin analogs, including the aspart, lispro, glolizin, or degludec. So even a 1% HbA1c reduction leads to significantly reduction in the complications. That is 21% reduction in deaths related to diabetes, 37% reduction in the microvascular complications, and 14% reduction in the MI. So what should be the target HbA1c? So there are various scenarios in which we can opt for a less stringent control or a more stringent control. Like if there is a young, newly diagnosed diabetic having low risk of hypoglycemia, we can opt for a more stringent control, as opposed to a elderly patient having long-standing diabetes, having higher risk of hypoglycemia. There we can opt for a less stringent control. Then also comorbidities and complications are important. If the complications and comorbidities are present, then we should opt for a less stringent control to prevent the hypoglycemia episodes. Patient attitude is also important. If there is a highly motivated person who is having excellent self-care capabilities, then we can opt for a more stringent control. Similarly, if the resources are readily available, for example, frequent blood glucose monitoring, HbA1c monitoring, continuous glucose monitoring, all the modern drugs being available, so in that scenario, we can opt for a more stringent control. So diabetes, cardiovascular and renal complications are all interconnected. So all these complications may be caused by diabetes, may contribute to diabetes, or may coexist with diabetes. And in Indian scenario, diabetes appears to be more of CV and renal risk than the hyperglycemic risk. Now we come to the first topic, that is the cardiovascular disease and type 2 diabetes. So ADA, which is the American Diabetes Association, it is the worldwide most reputed diabetes body. It recommends that irrespective of current HbA1c or the target HbA1c goal, and irrespective of the current therapy, we should start, add or replace SGLT2 inhibitor or a GLP-1 receptor agonist. So irrespective of current blood glucose, current medication, or what is our target, SGLT2 inhibitor or the GLP-1 agonist should be part of our treatment. So these are the various cardiovascular outcome trials which have been done for SGLT2 inhibitors, like EMPA-REG for empagliflozin, CANVAS for canagliflozin, DECLARE-TIMI for dapagliflozin, VERTIS-CV for ertugliflozin. All these trials show reduction in major adverse cardiac events as well as heart failure as well as CV death. So all the SGLT2 inhibitors help in the reduction of the cardiovascular disease mortality as well as morbidity. These are the similar newer heart failure data for the SGLT2 inhibitors, like DAPA-HF and DELIVER for dapagliflozin, EMPEROR reduced and preserved for empagliflozin, so SCORED and SOLOIST for sotagliflozin. Even all these studies also show significant reduction in the heart failure as well as cardiac death. So what is the mechanism of the SGLT2 inhibitors? Firstly, they do glycosuria, that is excretion of glucose, natriuresis, that is excretion of sodium, and diuresis, that is excretion of water. All these three mechanisms ultimately leads to improved cardiac function, reduction in the left ventricular mass, reduction in weight, as well as reduction in the blood pressure. The FDA, US FDA has approved the SGLT2 inhibitors even without diabetes in various scenarios. Like in ASCVD, that is atherosclerotic cardiovascular disease, canagliflozin and empagliflozin has been approved even in those without diabetes. For heart failure, dapagliflozin and empagliflozin has been approved. Similarly, in renal diseases, canagliflozin and dapagliflozin has been approved. So even in those patients who are not having diabetes, the SGLT2 inhibitors have significant benefits. So again, the thing which we had discussed firstly, ADA recommends SGLT2 inhibitors and GLP-1 agonists irrespective of the medication, irrespective of the goal, or irrespective of the target A1C. So that should be the mainstay of our treatment. Now we'll go in detail about the SGLT2. So the risk of the major adverse cardiac events, even when compared between dapagliflozin and empagliflozin, the dapagliflozin users showed reduced risk of hospitalization as well as heart failure related death. So dapagliflozin scored better over empagliflozin in the study. When it comes to DPP-4 inhibitors, that is the teneligliptin, vildagliptin and sitagliptin, they are generally cardiac neutral. They neither benefit nor worsen the cardiac events. And sitagliptin and linagliptin have shown marginal cardiovascular benefits. So they should be used on top of the SGLT2 inhibitors if the target A1C has not been achieved. Now we come to metformin. Metformin generally is the most commonly used drug, but rarely, if the patient is having heart failure, there is a increased risk of potentially lethal lactic acidosis. See, theoretically, lactic acidosis has been mentioned a lot, but practically lactic acidosis is not much seen, so we can use metformin freely as well. Now we come to sulfonylureas. Sulfonylureas are the most potent anti-hyperglycemic drugs, but so the incidence of hypoglycemia is also quite high in them. According to the EASD, that is the European Association of Diabetes, and ADA consensus, sulfonylureas are the last choice of drugs in people with diabetes because of their potential of hypoglycemia. However, when it comes to the second generation sulfonylureas like glimepiride, gliclazide, lesser incidence of hypoglycemia has been seen, and that has been established in various studies like Advance, Carolina, Tosca-IT, etc. When it comes to thiazolidinediones, pioglitazone has beneficial cardiac effects, but it is generally contraindicated in heart failure, mainly below an ejection fraction of 45%. So to summarize, for SGLT2 for the cardiovascular disease and type 2 diabetes, SGLT2 and GLP-1 receptors are the drugs of choice for patients with diabetes and ASCVD or heart failure. Although all the SGLT2s are same in this regard, dapagliflozin has more robust evidences. When it comes to DPP-4, all are almost cardiac neutral, but sitagliptin and linagliptin have been extensively studied. Metformin, though is widely used, it should be avoided in CCF because of the increased risk of lactic acidosis. Pioglitazone can be used freely except for heart failure. Second generation sulfonylureas like gliclazide, glimepiride can be used, but caution should be exerted for hypoglycemia. And aggressive blood pressure control and lipid management is also essential in all patients. Now we come to second part, that is the chronic kidney disease and type 2 diabetes. Now, risk of hypoglycemia increases with CKD progression due to three main causes. Firstly, renal gluconeogenesis is impaired due to the lower kidney mass in CKD. Secondly, the clearance of the insulin and oral medications is reduced. So, as a result of that, the action is prolonged, which leads to more chances of hypoglycemia. Anorexia and weight loss, which is related to uremia, also contributes to the hypoglycemic risk. So these are the three main parts which contribute to the hypoglycemia in CKD. Now, which are the drugs which should be preferred in the patients with CKD? Firstly, on the top of lifestyle modification in terms of regular exercise, weight loss, diet modification, metformin and SGLT2 inhibitors are the drugs of choice. But metformin should be given at a reduced dose in a GFR below 45 and should be discontinued on a patient having GFR below 30 or dialysis. Similarly, SGLT2 inhibitors should not be initiated below a GFR of 30. If the patient is already on SGLT2 inhibitor and the GFR reduces, then we can continue for a while. And it is contraindicated in dialysis. If the adequate blood glucose control is not achieved on these two medications, then we can move to the alternatives like DPP-4 inhibitors like linagliptin. We can go for ripaglinide. Then we can go for the shorter acting sulfonylureas like gliclazide. And ultimately, insulin is quite a potent anti-diabetic medication in CKD. So this is the timeline of the various SGLT2 inhibitors and the various outcome trials from the kidney point of view done. So they are the EMPA-REG for empagliflozin, CANVAS for canagliflozin, DAPA-CKD for dapagliflozin. So these are the various trials of SGLT2 inhibitors. So this is the DAPA-CKD trial. As you can see in the graph, that when dapagliflozin was given, there was a significant reduction in the renal death, end-stage renal disease, and subsequent decline of eGFR with the use of SGLT2 inhibitors. So again we come to the ADA guidelines. ADA recommends that preferably SGLT2 inhibitors with evidence of reducing CKD progression if eGFR is adequate, or if SGLT2 inhibitor is not tolerated or contraindicated, or if eGFR less than adequate, then we can opt for a GLP-1 receptor agonist. So here also SGLT2 receptor inhibitor and GLP-1 receptor agonists are the drug of choice. But we should be mindful that eGFR is not significantly low. Now we come to DPP-4 inhibitors. DPP-4 inhibitors as a class did not show any obvious renal benefits or any obvious adverse effects. But vildagliptin and sitagliptin should be given at a reduced dose, but linagliptin can be given freely in CKD because of its excretion by liver, while the other DPP-4 inhibitors are excreted by kidneys. So in them, the risks of hypoglycemia and potential renal damage are more. So linagliptin is the drug of choice amongst the DPP-4 inhibitors in CKD. Now we come to sulfonylureas. As we have seen, sulfonylureas should be used with caution in CKD because of their higher potential for hypoglycemia. But even in them, glipizide and gliclazide are relatively safer and can be given up to GFR of 30. Glimepiride can be used, but with a reduced dose below an eGFR of 60. Ripaglinide, which is a maglitinide, can be a safer option as compared to the other sulfonylureas up to a GFR of 30. So here also the hypoglycemia is the main concern, so we should use drugs where there is lesser chances of hypoglycemia. Now we come to metformin. In impaired renal function, the ability of the kidneys to excrete or metabolize the lactate is reduced, and metformin cause lactic acidosis. So in patients with moderate CKD, we should be careful in using metformin, and below 45 we should use reduced dose as we have discussed in the previous slides. When we come to pioglitazone, it is a safer molecule, but just care needs to be exerted that in heart failure patients water retention might be caused, so there we need to use it cautiously. So pearls of wisdom when it comes to CKD and diabetes. So for all patients of CKD, SGLT2 inhibitors are the drug of choice, but dose needs to be reduced at a GFR below 60 and should be discontinued at a GFR below 20. If SGLT2 inhibitor is not tolerated, we should move for GLP-1 agonist like semaglutide. Previously it was just available in the form of injections, but now an oral form is also available. Now DPP-4 are safe alternatives and no dose adjustment is needed for linagliptin. In the other DPP-4, some dose reduction must be needed. Sulfonylureas though are potent drugs but should be used with caution in CKD as there is a risk of hypoglycemia. And when it comes to pioglitazone, no dose adjustment except for heart failure we should avoid. Now we come to the third part, that is pregnancy and type 2 diabetes. So hyperglycemia is one of the most common medical disorders seen in women during pregnancy. The incidence is mainly increasing because of the lifestyle, because of urbanization, because of sedentary lifestyle, because of the increasing age of the pregnancy, and because the prevalence of type 2 diabetes is also increasing currently. Large-sized babies with perinatal complications are the main problem seen in patients having diabetes when they are pregnant. In pregnancy also, the hyperglycemia are of two types. Firstly, 75 to 90% of the cases of hyperglycemia are due to gestational diabetes, which are diagnosed in the second or third month of the diabetes of the pregnancy, and those patients are not having any history of diabetes previously. While 10 to 21% of the cases may be due to diabetes in pregnancy. Either it may be pre-existing type 1 or a pre-existing type 2 which antedates the pregnancy, or it is identified during the pregnancy for the first time in the index pregnancy. So when it comes to management, insulin is the preferred agent for management of both type 1 as well as type 2 diabetes because it does not cross the placenta. Whereas all the oral agents like metformin, glyburide, they cross the placenta and safety data is lacked in them. So again we come to the ADA guidelines. So initially we should opt for a basal bolus therapy only. In the basal bolus, the basal component should be covered by NPH insulin, which can be given once or twice a day, and regular insulin, which is the Actrapid. It can be given with all 3 meals according to the postprandial glucose targets. if the hypoglycemia is seen on the conventional basal bolus therapy, we can opt for the newer insulins, like instead of NPH, we can use Detimir as the basal insulin, and instead of regular insulin, we can opt for Aspart, Lispro or Glulicin as the bolus insulin, so that hypoglycemia is less. The newer insulins have a better dose adjustment, so they can also be given up to 20 minutes after the meals as well. So oral hypoglycemic agents, metformin and glyburide, though might be used, but both cross the placenta, with metformin likely crossing to a greater extent. Acarbose though has been used, but long-term safety data is required. Metformin is associated with a lower incidence of hypoglycemia and lower weight gain in mother, but it is associated with a higher rate of premature delivery, and as compared to insulin, fetus exposed to metformin are smaller in size at delivery, but these children have shown accelerated weight gain and obesity during their mid-childhood because of the metabolic disturbances. So because of that, metformin should be used cautiously, and before initiating metformin, the risk benefits of both the drugs should be explained to the patients in detail. So again, pearls of wisdom: hyperglycemia during pregnancy is associated with many perinatal complications. The target fasting and PP target are less than 90 and less than 130. That is, fasting less than 90, PP less than 130 in pregnancy. So these targets are more stricter than the normal population. Insulin is the mainstay of treatment with the basal bolus regimen, which should be followed. And for milder cases, after discussing the risks and benefits to the patient, metformin or glyburide can be considered in select cases. Now we come to the last part, that is elderly people and type 2 diabetes. So 1 out of 2 old persons are diabetic or pre-diabetic or
last 1 minute.
Or have some form of dysglycemia. So diabetes complications and comorbidities are also more frequently seen in the older patients because of the many physical, functional or cognitive problems. So the main compliance issues are seen in the older population of the drugs because of the functional capabilities. Some patients might not be able to move, some might not be able to remember the medicines. So compliance is also an important part. Some might take the medicines twice. So in such patients, we can opt for a more lenient HbA1c control, that is up to 7.5 to 8.5%, as opposed to a 7% in the conventional younger population. When it comes to metformin, it is a safe agent. Similarly, as you discussed before, lactic acidosis should be taken care of because of the risk of, because if the patient is having pneumonia or heart failure or other complications, and GI problems can be seen in some cases. Sulfonylureas, even they are a good agent, but if the patient is having long-standing diabetes, the beta cells are already depleted, so efficacy is a bit doubtful, and even in that population, hypoglycemia is a bigger concern. Pioglitazone, it is also a good alternative, but only should be avoided in the patients having CCF because of the fluid retention. Alpha glucosidase inhibitors, they are also a good agent, but they interfere with the absorption of carbohydrates. So if the patients are already having metabolic disturbances, having GI side effects like flatulence, diarrhea, if they are having nutrition deficiency, so in those we should use with caution. DPP-4 inhibitors are a safe alternative. So DPP-4 and GLP-1 are safer drugs in which there are no side effects, they don't cause hypoglycemia, they are weight neutral, so they should be the drug of choice. SGLT2 inhibitors can be used, but here also we need to exert caution, that is postural hypotension, dizziness, genital mycotic infections, as well as sarcopenia. The patients are already lean, and some patients might be lean, so in them it might cause further sarcopenia, so they should be used with caution. In those who are overweight, then we can use SGLT2 inhibitors. So pearls of wisdom: hypoglycemia episodes are common in elderly people, so they can be more hazardous. So we should prefer drugs which do not cause hypoglycemia, do not cause any infections, do not cause any weight gain. So metformin, DPP-4 inhibitors are the drugs of choice. In specific cases, SGLT2, sulfonylureas, insulin can be used with caution. So now paradigm shift is taking place in the management of diabetes. Initially it was just glucocentric, where A1C lowering was the main goal. But now it is a patient-centric approach. That is, we just don't target the HbA1c or the blood glucose, but we should also take care of the complications of diabetes. We should also take care about the comorbidities of diabetes, and we cannot go for a one-size-fits-all approach. We should individualize the treatment goals, because Diabetes management is much more than just controlling the blood sugar. Thank you.
Thank you so much, sir, for such an informative lecture on the drugs we have to use in day-to-day management. Any questions from the audience? I would like to call upon Dr. C.B. Patel, Dr. Yatish Lapsiwala sir, and Dr. Sujata Lapsiwala ma'am to felicitate Dr. Yash Lapsiwala sir.
Thank you, Yash. Now, after a heavy lunch and then mouth-watering sweets,